Dr. Sreejith has made significant clinical advancements in clinical practice and research, and significant contributions to the understanding and management of kidney disease, particularly in the areas of glomerular disease and CKD. He is also well known for his patient-centered approach and innovative insights, and is a sought-after speaker in all forums in nephrology, and is a thoughtful leader in the field. Today we welcome Dr. Sreejith to share his expertise on pancreas-kidney transplant, and we are definitely looking forward to your invaluable perspectives in this esteemed gathering, sir. I hand over the stage to you.
Thank you. Good afternoon, everyone. Thank you for the kind introduction and for the honor of being invited to this prestigious event. I'll be speaking briefly about the pancreas kidney transplant, not much on the surgical aspects, but primarily on how to identify a good candidate for pancreas and kidney transplant, and what are the options available and how good or bad these options are. So, why do pancreas transplant? Why don't we just do kidney transplant and stop with that? What are the, I specifically use the term B-cell replacement, because B-cell replacement need not necessarily be whole pancreas transplant. We'll be briefly discussing that. How to go about selecting patients and what are the parameters we should be considering there, and sort of an algorithm in choosing the treatment modalities. I will use a case. This patient didn't undergo pancreas transplant, but then to highlight these issues. So this was a 26-year-old lady who underwent disease donor kidney transplant with us in 2016, type 1 diabetic. At that point, she was 26. She was having type 1 diabetes for 13 years. She had a diabetic nephropathy with ESRD, and she was on CAPD. The reason she was on PD was she had very bad labile blood glucose levels going into frequent hypoglycemia. So we thought that probably she had difficulty continuing on hemodialysis. So it was not because of any vascular access issue. Okay, she was having hyperglycemia and she was probably not having much hypoglycemia while on PD. So that is why she was on PD. She was on PD for almost 2 years. She had proliferative retinopathy. She had peripheral neuropathy. She had clinical features suggestive of gastric dysmotility also, even though the gastric emptying study didn't show thing, but we thought that she also had gastric dysmotility. She had highly labile blood glucose level. One of the reasons why she was on PD, she was having a BMI of 17, so she was undernourished. And she had no living kidney donors from among near relatives. We do only the near related donors, so she was waitlisted for disease donor transplant. So the question is, what is the best transplantation option for her? Right. So there are that brings us to the question, what is the relevance of pancreatic transplant? So the goal in treatment, we can give her a kidney. If there is a disease donor, she will get a kidney, but then her problems will not end with that, right? She has problems with her glycemic control. We would like to eliminate risk of problematic hypoglycemia if possible. And when you do transplant, when you give tacrolimus, prednisolone and all, the difficulty in glycemic control is likely to increase rather than decrease. And we would like to definitely, she has problems with quality of life related to diabetes control and diabetes complications. So that also we would like to address. So none of these will be addressed by kidney transplant alone. And we know that the best long-term outcomes are with regard to either insulin independence or metabolic control comes from pancreas plus kidney transplant, right? So there are compelling reasons. I'll be sharing some data also on the outcomes when not doing kidney transplant alone in patients like this. So what are the options available? If you look at the history, like any other transplant or even surgical options, this started as surgical adventures, so to say, in the late 60s. People have tried. So the surgical challenges with pancreas transplant is even more complex, because we don't know how to people didn't know how to deal with the exocrine component of the pancreas. Okay, we only needed the beta cells, but then you can't separate the two. Pancreas comes with the exocrine component also. People have tried many things, using some plugs to block the duct, irradiating the pancreas to stop the exocrine function, but none of them practically worked. So there are two things which change the course of pancreatic transplant, the fate of pancreatic transplant program. One is a surgical thing where they started the surgeon started connecting the exocrine duct to the bladder, urinary bladder. So that happened in the late 80s, where they devised a new surgical technique where the pancreatic duct is connected to the urinary bladder so that the exocrine secretions goes into the urine. This had complications, so later on this was again changed. Now that is not the modality surgical procedure done. It is a there is something called a duodenectomy, or more advanced is the duodenostomy, right? So that is one surgical advancement which made pancreatic transplant more feasible and widespread. And the second is obviously immunosuppression, because prior to that people were using steroid and radiation and azathioprine. With the advent of first cyclosporin and then tacrolimus followed by MMF, the immunosuppression also became more reliable, and the rejection rates and all came down. So there are two things. After 80s, why the pancreatic transplant became, I would say, a practical, a feasible option. What are the types of beta cell replacement? It can be a pancreas transplant alone. I'll be using these short forms in many of these slides. So PTA is pancreas transplant alone. PAK is pancreas after kidney transplant, where the patient undergoes kidney transplant first and then later on at a later date undergoes pancreatic transplant. Simultaneous pancreas and kidney transplant in the same sitting is SPK. And when you have the kidney coming from a living donor and the pancreas coming from deceased donor, it is called a simultaneous deceased donor pancreas with living donor kidney transplant. And then islet transplant. So simultaneous islet kidney, where you don't do the pancreas but islet with the kidney, is SIK. And islet after kidney, just like you do pancreas at a later date, first you do kidney transplant and then you do islet transplant at a later date. How this is done, how you decide, I'll be coming to in a subsequent slide. If you look at the number of pancreatic transplants happening, the number seems to have stagnated over the last, I would say, a couple of decades. And if you look at the US data, it is decreasing, whereas non-US data, it is increasing. This is primarily contributed by European countries and China, apparently. The reason the number of pancreatic transplant has decreased is due to two reasons. One is improvement in glycemic control. You have continuous glucose monitoring, you have insulin delivery devices, so that is improving your ability to have a better glycemic control. The second part is the quality of pancreatic donor. You don't want, and recipients have changed. It is difficult to do pancreatic transplant. It's a relative contraindication to do in obese patients. That is also true when the donor, when the deceased donor is obese. So the quality of pancreatic, the donor pancreas or the donor, as well as there is a decreased requirement from the recipient part also. That is why the number of, seems to be the reason why pancreatic numbers, not because of any surgical reasons or poor outcomes per se. Whereas outside US, especially in China, the number seems to be exponentially increasing, which is expected. I'm sure India will join that group soon because of the increasing number of diabetic and ESRD population here. And most of the transplants are obviously SPK, simultaneous pancreas and kidney, followed by pancreas after kidney. All other forms are relatively infrequent. Patient selection, there are two broad rules. Pancreas you do for people who are relatively young, who are insulin dependent, without major cardiovascular or surgical risk. So people with extensive vascular disease, people who are poor surgical candidates, probably because the surgery is more complicated and you can have more complications perioperative. And those who require kidney transplant. So insulin dependent diabetes, most of them will be type 1 diabetes, but there are a subgroup of type 2 diabetes and other diabetes also. I'll be coming to that. So insulin requiring, difficult to control diabetes, relatively young, a good surgical risk, no significant comorbidities, and who has advanced kidney disease or kidney failure requiring dialysis. And islet transplant, when such a patient is not a good candidate for pancreas, you can opt for islet transplant because it is a low risk procedure. And there are various parameters by which we decide this, like type of diabetes, what sort of diabetes the patient is having, degree of reduction of the level of their kidney function when they are being considered, degree of glycemic instability, and I will be discussing one by one. So let us look at each of these. Diabetes, insulin-dependent diabetes means most of them will be type 1 diabetes, and there the treatment of choice is kidneys. And so that much is clear. Type 1 diabetes, ESRD, non-obese, the treatment of choice is kidney and pancreas. Okay. So when we have this type 1 diabetes, for some reason has been very infrequent in our practice, we counsel them for pancreas and kidney, but practically none of them are able to go for pancreas because they can't afford it. Type 1 diabetes, obviously, and selected cases of type 2 DM and other types of diabetes. For example, somebody who has had chronic pancreatitis. So basically, there is a deficiency of insulin secretion. C-peptide is low. So that is the criteria. Type 1 diabetes, that is the pathology, or a other type of diabetes where the primary problem is not insulin resistance. Chronic pancreatitis, pancreatectomy, cystic fibrosis, and type 3 MODY, HNF1 alpha mutation, and some mitochondrial cytopathies will be considered eligible for pancreatic transplant, unlike other diabetes. Then the question is how to differentiate. People will think it is very easy to differentiate between type 1 and type 2, which is if you are seeing patients, I am sure, because we tend to do a significant number of relatively young people with the diabetes. So I will not say it is clinically easy to differentiate between type 1 and type 2, even though we may think so. So there are criteria by which this is to be done. Type 1 diabetes, so one of the common things supposed to be done is to look for autoantibodies associated with type 1 diabetes and a C-peptide level. There is a catch with the C-peptide level because the level can go up with reduction in GFR, right? So it may not be as low as in somebody with, usually in type 1 diabetes it will be undetectable or very low, less than 0.3 nanogram per ml, whereas in people with CKD the level may be higher even in people who are having type 1 diabetes. So generally, if the presence of C-peptide more than 2, a higher cutoff is used in renal failure patient, in the presence of renal failure compared to people with normal renal function. If you have C-peptide level more than 2 and the autoantibodies are absent, then you can reasonably assume that this is type 2 diabetes and not type 1 diabetes. Pancreas transplant in type 2 DM is an option, even though that is infrequent. People who are not obese, so they should not be obese because obesity is usually associated with insulin resistance. Pancreas transplant is unlikely to be of use. Insulin resistance, where the requirement of insulin dose is more than 1 unit per kg, so, and low cardiovascular risk. So those people who are not requiring very high dose of insulin, who are not obese and who don't have high cardiovascular disease, and as of now, apparently, around, I would say, 10 to 20% of transplants, pancreas transplants, are for indeed type 2 diabetes patients. So it's not contraindicated. We have to carefully choose those type 2 diabetes where you will offer pancreas transplant. Depending upon the kidney function, again, you have to be careful because if you look at, say, somebody with the GFR between 30 to 40, 30 to 60, they have low GFR. They may be having other problems with glycemic control, but if you do, there is no indication for a kidney transplant there, but then if you offer pancreas transplant or an islet transplant, they have to be on immunosuppression, right? They will give a tacrolimus, so that is prescribed. They are going to have renal failure soon, so you're going to precipitate ESRD in them. The renal function is bound to worsen with immunosuppression, including CNI. So this group is usually not pancreas transplant is not recommended for them, including islet transplant that also requires immunosuppression. Sometimes you may need more immunosuppression with islet transplant. So people who are in stage 4, stage 5, already on dialysis or expected to require dialysis soon, and have other indications like type 1 diabetes and other problems are referred for pancreatic transplant. And a selected group of people with relatively preserved GFR may be considered for pancreas alone. It may be pancreas alone or islet alone. Okay, but then you have to be very, very careful. You have to do when it is really indicated. There is significant quality of life issues with the hypoglycemia, unawareness, life-threatening hypoglycemia happening, and with the understanding that the patient may have accelerated decline of GFR requiring transplant. For example, if you have a backup living kidney donor whom you can use if the patient develops renal failure at a later date, with that understanding, you can consider that person also a candidate for pancreas alone transplant or islet transplant without kidney transplantation. Problematic hypoglycemia and hyperglycemia. So what is problematic? That is also clearly defined. Problematic hypoglycemia is when you have 2 or more episodes per year of severe hypoglycemia, or one episode with impaired awareness of hypoglycemia or associated with maladaptive behavior. The patient became so concerned about the episode that functioning is affected. So these are classic indications for beta cell replacement therapy, primarily pancreatic transplant or islet transplant. Problematic hyperglycemia. So it may be hypoglycemia or hyperglycemia, and I'm sure you will know that most of these people actually tend to have what we used to call brittle diabetes, where it either goes one way or the other way. It is never within the range you need. So presence of recurrent episodes of diabetic ketoacidosis is one other indication. So it is either problematic hypoglycemia or hyperglycemia. Quality of life considerations, diabetes, and so even when they don't have an indication for kidney transplant, you may still consider the option of pancreatic transplant when they have serious issues with quality of life from complications from diabetes. And invariably, be it the transplant, generally the quality of life improves. SPK is better than before and after. There are studies showing this. There is significant improvement in quality of life versus SPK and kidney transplant alone, before SPK, after SPK, and all. So that is one consideration. Other is obesity. Obesity is bad for transplant. For the recipient, there is high risk of perioperative complications, graft thrombosis, and technique failure. And the long-term graft survival also of the pancreas is compromised. So obesity is generally considered a contraindication, but people are doing now after bariatric surgery also. So if patient is obese, is unable to lose weight, then the other option is to first do bariatric surgery, bring down the BMI, and then do the pancreatic transplant. So that is also being practiced now. Vascular disease, as we all know, is very common in diabetic, and is even more when the patient is having diabetes and kidney disease. So they usually tend to have poor cardiovascular risk, so they may not be a candidate for transplant. In addition, there may be technical issue from arterial calcification, which is also very common, as you must be seeing in our patients. A dialysis patient, they have vascular calcification. We can again increase the technical difficulties with pancreatic transplant. So a thorough evaluation, and if you find significant cardiovascular morbidity or vascular calcification, that may preclude pancreatic transplant. Frailty is another consideration, because that is known to be associated with poor outcomes. Immediate early transplant perioperative risk as well as long-term outcomes are poorer when you have frail patients. Like this patient had a BMI of 17. And most of our dialysis patients tends to be frail. So you have to be careful. If the patient should not be obese, the patient should not be too frail as well. So what are the transplant options? I listed a lot of pancreas, before pancreas, after kidney, simultaneous pancreas, islets. How do we go about doing this, selecting patients? First is when to refer. When should, suppose you have a type 1 diabetic patient with CKD, at what point should we refer the patient for evaluation? I think some of this will differ in our situation. I will come to that, because the disease donor allocation generally in our situation prioritizes when somebody needs 2 organs. Pancreas plus kidney becomes 2. Liver plus kidney becomes 2. So people who are waitlisted are likely to be prioritized for allocation, but that seems to be not the case in some other countries. Once the GFR is below 30 ml, we are supposed to refer the patient for consideration for pancreatic transplant plus kidney, of course. Or if somebody has fast decline in GFR, defined as more than 5 ml per year. And this early referral is likely to, like in most RRT options, likely to improve the outcomes. One important consideration is when somebody has kidney disease and is being thought of, okay, can we do kidney and pancreas, is whether they have a living kidney donor, right? So here, you may not have pancreas really available, but you can, if living kidney donor is there, you can do it. So should we do kidney transplant now and later on kidney pancreas? And are the outcomes different? The outcomes are indeed different. If you again, these are not randomized. There may be biases from the way it is done, retrospective data. But then, compared to kidney transplant alone, the 4-year patient survival was better when the patient undergo patient who were waitlisted for. So suppose somebody waits for kidney and pancreas, and somebody undergoes kidney transplant. The people who underwent kidney alone fare better compared to those who were waiting on dialysis. So patients on or close to dialysis with a suitable living kidney donor may benefit from kidney transplant alone, and you can plan pancreatic transplant at a later date. And this holds true even when you have to go in for paired exchanges because of ABN compatibility or sensitization. Even then, it is better to do the kidney transplant first, followed by pancreas at a later date when it becomes available. Comparing kidney transplant alone with simultaneous pancreas and kidney transplant, the short-term complications are less with kidney transplant alone. because it is simpler surgery. Lower surgical morbidity and mortality with kidney transplant alone, whereas the complication rates, the surgical complications are more with simultaneous kidney and pancreas. But the long-term survival, both the graft survival, patient survival, and the pancreas graft survival is also better with SPK compared to kidney transplant alone. Sorry, no, pancreas transplant is not there in kidney transplant, but the patient survival, cardiovascular event, all-cause mortality are less with simultaneous kidney and pancreas transplant compared to doing kidney transplant alone. So the right strategy probably is, if you don't have pancreas, go ahead with kidney transplant, but as soon as possible, go ahead with the pancreas transplant at a later date. SPK, the long-term survival benefits I already told, is cardiovascular events as well as kidney allograft survival is better. The pancreas allograft survival at this looks too optimistic, but then we don't have data. 10 years seems to be 75%, 25%, 13%. The allograft failure, by the way, is defined by insulin requirement, is by metabolic. If the insulin requirement after islet or pancreas transplant is more than 0.5 milligram per kg per day, then it is labeled as a pancreatic allograft failure. So it is based on the insulin requirement, right? So somebody may be requiring insulin, but may not be labeled as graft loss if the requirement is less. So pancreas with living kidney donor is an alternative to simultaneous kidney and pancreas when the waiting period for deceased donor is long, which is unlikely to be in our case. Our case anyway, if you are waiting for deceased donor, you are more likely to get the kidney and the pancreas if you are waiting for both. But this may be applicable in some other situation. So if you have a situation where you have a readily available kidney donor, pancreas from the deceased donor is not, you have to go wait for a longer time, it makes sense to go ahead with the kidney transplant. Or if you have pancreas available, you can time it in such a way that you do living donor kidney plus pancreas in the same sitting, which is going to be logistically challenging. So it is a very infrequent surgery, right? But that possibility is there. And when you have somebody with disease donor, so type 1 diabetes waiting for disease donor kidney transplant, and simultaneous islet and kidney, where will you do? You have somebody waiting, you have a living donor, patient is not a candidate for pancreas, then you can do islet along with kidney as well. So these two options are available, and islet you will consider when the patient is unfit for your pancreas transplant. Pancreas after kidney transplant is usually when a type 1 diabetic has already undergone kidney transplant alone, which may be living donor or a deceased donor. Our patient underwent a deceased donor transplant. It's possible that you went ahead with the living donor transplant. And selected insulin dependent type 2 diabetes also, when they have difficulty with regard to achieving glycemic, it may be hypoglycemia, it may be hyperglycemia, and the GFR is after a kidney transplant, unless the graft function is good, you should not go for a pancreatic transplant. So the GFR should be at least 40 to 45 ml or more to consider a pancreatic transplant after kidney transplant. And the kidney graft survival is better when you do pancreas after kidney transplant compared to kidney transplant alone, probably because of better glycemic control and graft loss, maybe less from diabetic nephropathy recurring in the graft. And the pancreatic allograft survival is also better versus in simultaneous kidney and pancreas transplant, the survival is better compared to pancreas after kidney transplant. So whatever way you look at it, looks like if it is feasible, simultaneous kidney and pancreas is the best option. Islet after kidney transplant, this is usually reserved for those people who are not candidates for pancreas because of surgical morbidity or morbidity from cardiovascular disease, and the outcomes are inferior compared to pancreas transplant. So 28% at 10 years, 45%, this is insulin dependence. It is much less compared to pancreas transplant. But then they may have significant improvement with regard to glycemic control and as well as quality of life. So it may be worth trying. At least there is one RCT. Mostly this data is from retrospective data. There is an RCT which compared islet transplant, either islet transplant alone or islet after kidney, compared with intensive insulin therapy, and the follow-up was only for 6 months, but it showed metabolic control, be it insulin dose requirement, be it occurrence of life-threatening hypoglycemia, as well as HbA1c was much better when the patient received an islet transplant compared to remaining on intensive insulin therapy. So how do you decide between pancreas and whole pancreas and islet? So these are the advantages. Pancreas, the long-term patient survival is better. Long-term insulin independence is there compared to islet transplant, and there is improved quality of life. Disadvantage is surgical risk is more when you do pancreas, primarily because of the exocrine thing. Early graft failure from rates are there compared to islet transplant. The technical failure can be there from thrombosis and pancreatitis. And technical reasons, patient may be vascular disease, it may be contraindicated. Whereas these are the people who are candidates for islet alone transplant, where this is a minimally invasive procedure. Basically, you are putting a catheter into the portal vein and infusing the islet cells into your portal vein, so it is not a major surgery. Long-term graft function with better glycemic control, up to 75% at 10 years, they have better improved quality of life as well. They have improved in the sense, suppose they are not given graft survival with regard to the kidney transplant we are talking about, and improved quality of life. Insulin dependence is much less. It is almost 50% less compared to people who have whole pancreas transplant, and they may require multiple donors. The problem with multiple donor is that their chances of sensitization is more. So they may require more immunosuppression. They may have more rejection episodes. With islet alone transplant, because it is multiple donors, pulled from multiple donors. So how do you go about if you have a patient with type 1 diabetes and advanced kidney disease? Patient, you refer early once the GFR is less than 30 ml. First, you look at whether the patient is a pancreatic candidate or not. If the patient is not a candidate for pancreatic transplant, like for example, type 2 diabetes, obesity, glycemic control is okay, they will not be considered for pancreatic transplant. If they are, then you look at the expected waiting time and availability of living donor. If there is a living donor and the waiting period for pancreas is long, then you go ahead with the kidney transplant, living donor kidney transplant, or if you're able to manage pancreas from a deceased donor, you do simultaneous pancreas with kidney from the living donor. And after the living donor transplant is done, then you reassess whether the patient is having now problematic hypoglycemia or hyperglycemia. You're looking at whether the patient really needs pancreas. Some of them may not need. And if they really need, then you can go ahead with pancreatic transplant. But they need, and their risk is more. Either cardiovascular risk is more, comorbidities are there. Then instead of going for pancreatic transplant, you do insulin, islet alone transplant, right? And if the patient is the waiting period is short, patient is able to get in your program waiting period for deceased donor pancreas with kidney is short, then you don't go for living donor, you go ahead with the, and you don't have a living donor, you go ahead with simultaneous kidney and pancreas transplant, which seems to be the most common thing done. If the patient is not a candidate for pancreas, then high morbidity or older age, then you do kidney alone, right? If it is obese, insulin requirement is more, there's no point in doing islet. So if the patient is not obese, patient is not requiring high dose of insulin, then in this patient you can consider islet alone transplant. You will not do pancreatic transplant. If that is not the case, patient is obese, patient is requiring high doses of insulin, then you do kidney alone, either deceased donor or living donor. Then you reassess the patient and whether the patient really needs pancreas now. And if the patient really needs pancreas, then you do islet alone transplant. No, otherwise, no, you keep the patient on insulin, intensive insulin therapy, maybe use continuous glucose monitoring or advanced technology to deliver insulin. So that's it. Basically, if you have somebody with beta cell dysfunction, basically type 1 diabetes or another type of diabetes where insulin resistance is not predominant, you are having problem with quality of life from diabetes, then we need to consider the option of beta cell replacement, mostly in the form of pancreatic transplant or also in the form of islet transplant. And this has to be individualized based on multiple parameters like the comorbidities, the availability of a living donor, and the waiting period for deceased donor transplant. But this seems to be a good option for those people who are candidates for pancreatic transplant. Thank you once again for having me.
Thank you, sir, for your enlightening and detailed talk on the latest updates in pancreas kidney transplantation. Your expertise has offered us valuable insights into the advancements and evolving practices in this critical area, enhancing our understanding of its impact on patient care. So we have a few audience questions. The first question, since most patients who undergo a simultaneous pancreas kidney transplant are unlikely to be off hypoglycemic agents, so is an SPK really worth it? As it is, pancreas biopsy is not as easy as a transplant kidney biopsy, apart from the surgical challenges that are involved with the SPK.
So I think the data on this, I think, is pretty clear that it does make a difference. Okay, a patient, it is not a question about, even people may require insulin also, but then there are many things which happen. One, the life-threatening hypoglycemia. If the people who have hypoglycemia unawareness, that the awareness seems to be improving after pancreas transplant. I don't know the mechanism, but it is well described. The life-threatening episodes of hypoglycemia, basically the diabetes becomes better controlled with long-term advantages with regard to diabetes, for example, retinopathy, peripheral neuropathy, cardiovascular disease. So, and there are, okay, these are not RCTs, but if you look at available evidence, I think it is pretty clear that the patient may require insulin or even drugs, but then their quality of life as well as cardiovascular and overall survival seems to be better if you do pancreas and kidney instead of doing kidney alone or leaving them on dialysis. So it's worth doing is what the data says.
Thank you, sir. So most of the other questions you have covered in your topic regarding
the rejection. Again, one strategy which I have only theoretical knowledge about it is to do most of the thing, and the new modality where you have duodenostomy, not the duodenojejunectomy, you can do endoscopic biopsy of the pancreas. So if you are doing that, which is more recent surgical technique, you can biopsy the pancreas. And in most of the other situations, people are biopsying the kidney when they are suspecting rejection. But the concordance rate is poor. It's only around 40%. Concordance rate is poor, but that is what is done. So it's not that you cannot biopsy at all. There are ways to do that also.
Thank you, sir. Most of the other questions you have already covered in your talk.
Thank you.